Hi, this is Engin from Istanbul. Good morning, good afternoon, and good evening, wherever you want. Today, this is our UKSEAD webinar will be in a few minutes, and we will start with the three distinguished speakers. One of them is from Turkey, Dr. Ahmet Kale. Two other will be from Russia and the United States. And from Russia, Dr. Alexander Popov will be our guest. As you know him very well, he is working in Moscow in a gynecology oncology surgery department in Moscow Regional Scientific Research Institute. He is very famous about laparoscopic surgery and the robotic surgery for endometrial adenomyosis and the pelvic surgery as a pelvic surgeon. And the next one will be Dr. Gabi Mohammed from the USA, Washington, well-known international robotic and laparoscopic surgeon for the advanced pelvic surgery. And Dr. Kale is from our society board member, UKSEAD and the Adenomyosis Society, and he is working in the Health Science University as a chief education. And this we prepared together with Dr. Ahmet Kale the program of this webinar. We will speak about adenomyosis and fibroids, especially surgery. We have three subjects, and you will ask the question at the end of the webinar as a Turkish or English. It's up to you. And the first speaker will be Ahmet Kale. He will speak about radiofrequency ablation for the fibroid treatment. Please, Dr. Kale.
Thank you very much, President Dr. Engin Oral. Good evening to everyone. My topic is the role of radiofrequency ablation in the management of uterine fibroids. As you know that leiomyomas are benign tumors that develop from the muscle and connective tissue of the uterus. And as we see that it can be seen most commonly in the reproductive age of women. And there are different types of fibroids, intramural, subserosal, pedunculated, and submucosal myomas we can encounter with the patients. If you look at the incidence, it ranges from the 30% to the 50%. It changes, the range or the distribution changes from patient to patient. How can we classify the myomas? The FIGO classified the myomas. As you see that in the left side from 0 to 8, it can be classified as a FIGO classification. It can be classified as a location of the myomas in the uterus. And also, if you look at the symptoms, it can be the patient encounter with or to come to our office with a heavy prolonged menses, sometimes pelvic pressures. Sometimes urinary and bowel symptoms could occur in the patient in myomas, but most of the times the patient can be also a asymptomatic patient, can come to our office. During gynecologic and ultrasonographic examination, it is very easy to see the myomas in the uterus. As you see that hypoechoic or heterogeneous solid mass, it is the border is very well defined. And sometimes it may distort the uterine cavity or uterine contour. If you look at the MRI, as you see that the T1 or T2 weighted image, as you see that it might resemble like a low signal intensity could be seen in the MRI findings. In our practice, we can treat the myomas such as we can only follow the myomas, don't do anything to the myomas. Sometimes we can offer a medical treatment. Sometimes we can offer surgery such as myomectomy. If the patient has an advanced age, we can also perform hysterectomy. But now there's an emerging techniques. It is called a radiofrequency ablation. Radiofrequency ablation is a novel solution for treating uterine fibroids. If you look at the candidates for radiofrequency ablation for myoma uteri, if the patient wish to delay her pregnancy, if some patients comes to our office and says that I don't want to surgery, please offer me another option for myoma uteri. I don't want to undergo the surgery. In these cases, we can offer a radiofrequency ablation. Sometimes the patient preserve uterus even if she has an advanced age. In some patients, the patient has some comorbidities such as obesity and cardiac disease and coagulopathy. It means that the surgery carries a high risk in these patients. In these patients, also the radiofrequency ablation is very suitable. It is a non-invasive therapy, and during the operation, we perform the radiofrequency ablation with a transvaginal wave. So there is no incision at the end of the procedure, and it is a very short procedure. It takes approximately 20 minutes or 30 minutes maximum. So it is a very short procedure. How does the radiofrequency ablation works? First of all, it generates thermal effects inside the myoma. It means that it makes a coagulation necrosis, and also it makes a vascular thrombosis inside the blood vessels of the myoma, and also inactivate the hormonal receptors during the procedures. It is a working mechanism of the radiofrequency ablation. What do we need during the procedure? First of all, we need a generator for heating or coagulating of the myoma, and we need a needle. It is called a radiofrequency electrode, and for guidance we need a ultrasonography, and we use during these procedures most of the time a transvaginal route. Which type of myoma is suitable for radiofrequency ablation? If you search or look at the literatures, up to 7 centimeter myomas is suitable, and not more than 3 myomas is suitable for radiofrequency ablation. If you look at for the FIGO types, which type of myomas is much more suitable for this surgery or for this procedure? Type 2, as you see that intramural. Type 4 is mostly intramural, and type 5 myomas is much more highly suitable for this type of procedure. It is a very short video that is explaining the uterine fibroid of radiofrequency ablation, how we perform. We need at the beginning of my speech, we need a generator and to form a coagulation necrosis inside the myoma. And we need a needle. This needle should be an adjustable needle. The tip of the needle is adjustable according to the myoma size. As you see, it's an adjustable needle. We need a transvaginal ultrasound scan, and also in dorsal lithotomy position, we begin to perform this procedure. And also we are applying a ground pads, at least 2, sometimes 4 pads. We are putting on the surface of the patient. And with the ultrasonographic guidance, we are beginning the radiofrequency ablation. As you see that this needle is like an oocyte pickup. We are entering inside the myoma. As you see, it is as you see that hyperechogenic tip or needle is seeing inside the myoma. And afterwards, if we sure that we are inside the myoma, we are beginning to generate the heat inside the myoma. As you see that hypoechoic region becomes an enlarged hyperechoic region inside the myoma during this procedure. And at least 80% of the hypoechoic region turns into hyperechoic region. It means that whitening of the surrounding site of the myoma. It means that we completely stop the procedures. So as you see that there are some hypoechoic areas, and we are stepping procedures. And after, first of all, we are performing coagulation necrosis inside, and afterwards we are withdrawing needle a little bit to target the hypoechoic area. And afterwards, we are again activating the tip of the needle. And at the end of, as you see that the hyperechoic rim is seen. So we are completing the procedure. It takes approximately 20 minutes in a under sedation of the general under sedation anesthesia. If we look at the review of literature regarding with the radiofrequency ablation, as you know, there is a 364 patient is included this review of literature, And if you look at the quality of life scores, as you see that at least 50% of the quality of life scores increased after the procedures, and it maintained at least 3 years. And it is a very alternative and good procedures. Thus, really, this type of radiofrequency ablation decreases menstrual bleeding, yes, especially for FIGO type 3, 4, and 5 myomas. At the end of the 1 year, if you perform and if you follow up the patients, at least 50% or 45% of the patients says that, yes, my menstrual bleeding decreased at the end of the 1 year. So it is really beneficial procedure. It's another study from the Spain. The Spain is very pioneer, especially for this radiofrequency ablation operations. They 59% underwent uterine myoma surgery. As you see that at the end of the 1 year or 1 year, more than 80% of the myoma volume decreased. If you look at the menstrual bleeding pattern, as you see that at least 70% of the patients explains that, yes, my menstrual bleeding was reduced approximately 70%. It means that it is very good point. Does radiofrequency ablation of the myomas have some pregnancy outcomes? Yes, there is another review of literature. This literature or review includes 922 radiofrequency patients underwent radiofrequency ablation methods, and 44 full-term pregnancies occurred at the end of the pregnancies. If you look at the results or outcomes, most of the deliveries performed with vaginal way, and the miscarriage rate is the same as the general obstetric population. There isn't any uterine rupture. It is important. There is no invasive placentation after radiofrequency ablation. There is no intrauterine adhesions. In terms of fertility, there is no negative impact on the fertility issues. There are some concerns about whether we are performing radiofrequency ablation and does it really decrease the uterine volume, or does it really decrease the uterine wall thickness? No. This is another study, and they look at the MR wall, uterine wall thickness at the end of the 1 year with the radiofrequency ablation. As you see that at the end of the 1 year, there is no uterine wall thickness difference between the pre and postoperative values, so it doesn't affect the uterine wall thicknesses. Another concern is that does really the radiofrequency ablation occurs at the end of the procedure intrauterine adhesions? No. This is another study from the Netherlands, and 34 patients underwent this operation, radiofrequency ablation, but baseline hysteroscopy was performed all the patients. After the procedures, 6 weeks later, hysteroscopy was performed. They didn't see any new intrauterine adhesions after radiofrequency ablation. So they conclude that there is no intrauterine adhesions after radiofrequency ablation methods. Is there any difference between the radiofrequency ablation and laparoscopic myomectomy? This study is compare radiofrequency ablation versus laparoscopic myomectomy. As you see that there isn't any difference between the heavy menstrual bleeding, dyspareunia, urinary frequency. So outcomes is the same with the laparoscopic radiofrequency versus laparoscopic myomectomy. If you look at the hospital stay, laparoscopic radiofrequency ablation is much more shorter. Blood loss is much less. Procedure time is really very shorter, approximately 15 or 20 minutes. And equipment use much more less in radiofrequency ablation. Return to work is very faster. So in terms of this hospital stay, blood loss, and procedure time, it is much more beneficial when compared with the laparoscopic myomectomy. Which patients is much more suitable or carrying advantages, especially if the patient has more than 40 years of age, we can expect a greater reduction in myome size. And also if we operate the smaller myomas, especially 4 or 5 centimeter at the beginning, the decrease of the myoma size is much more better with this procedure. Do we encounter some complications? Yes, but it is less than 1%, and most complications are mild and self-limited. We should inform the patients about the complications. After the procedures, the patient complains about some complications such as pelvic pain, cramping, low-grade fever, and vaginal discharge. It is a self-limited. It doesn't extend more than 1 week, especially. So we should inform before the procedure to the patient this kind of mild or minimal complications. But rare, but some serious complications could occur, especially if we perform if the bowel or bladder is very near during the myoma. If you don't guide our needle very well, if we cannot control, in these cases, we can burn the bowel or bladder, but this serious complication is less. But if you look at the literature, yes, these complications is mentioned about, but it is not more than 1%. If you look at the recurrence rate, it is approximately 4%. Reintervention rate is approximately 11%. It means that after the procedure, some patients complain about that my bleeding is persisting, and my pain is persisting. In these cases, you should offer another operation, such as myomectomy, such as hysterectomy, or another operations you should offer the patients. So reintervention rate is approximately 10% at the end of these procedures. This is our preliminary results, and we begin these procedures at the beginning of this year. This is an ongoing study. We are continuing to operate these patients with radiofrequency ablation, and 24 of patients included this study, especially fibroid types is type 3, 4, and 5. After the radiofrequency ablation, we look at the early results of the patients, and as you see that menstrual bleeding decreased at the end of the 3 months is 50%, pain score decreased 50%, and fibroid volume decreased 50%. If you look at the literature, at the end of the 1 year, approximately 70 or 80% of the menstrual bleeding, pain scores, and fibroid volume is decreased. So we should be patient we should wait. And also we should also inform the patient that you should be patient about the menstrual bleeding, pain scores, and fibroid volume. It is beneficial. And these procedures last at least 3 years. So menstrual bleeding patterns, pain scores, and fibroid volume persist at least 2 years. It means that it is beneficial in long term. What is AAGL says about or tells about what is their opinion about the radiofrequency ablation? Their idea is that there needs still randomized controlled trials. However, available studies consistently show that it reduced uterine volume, improved uterine bleeding, and it provides a better quality of life to the patient. So AAGL also accept is another treatment modality for myoma uteri. If you look at the American College of Obstetrician Gynecologist Society, they also share the same idea and that radiofrequency ablation is a minimally invasive surgery, and if the women preserve or wish to preserve their uterus, it is an alternative surgery or alternative procedure, not surgery, especially for procedure, we can say that procedure, especially for treating symptomatic uterine fibroids. And it is a day cave procedure. After the procedure, you can follow the patients 2 or 3 hours in your clinic, and you can discharge the patient at the end of the procedures. Briefly, it is an outpatient procedures. It is a minimally invasive procedure. The procedure time, as I said at the beginning of my talk, it takes approximately 20 minutes. If you ablate more than 1 or 2 or 3 myomas, it takes a little bit more times. You can at least for each myomas, you can at least add 10 minutes, not more than 10 minutes for each myoma. So it's a short procedure time. The patient return their daily activities very quickly, and after the procedures, the patient can go their work 1 or 2 days later. So it is the recovery period is very fast, and complication rate is very low in especially an experienced stand, and the procedure takes time. At least if you perform at least 20 procedures in different times, the learning curve is at least 15 or 20 cases. Afterwards, you will be very experienced about these procedures. Now, at the end of my speech, World Congress Endometriosis will be held in 2027 in Istanbul, Turkey. And this is organized by the Turkish Endometriosis and Adenomyosis Society. And president of this congress is Dr. Engin Oral. So we are all inviting you to this kind of very scientific, very valuable congress from all over the world. Thank you very much.
Thank you, Dr. Kale, and for the good summary and with your experience is it important for us. Just one thing, the Endometriosis World Endometriosis Congress will be in Istanbul under the auspices of the World Endometriosis Society, and there will be two president, one of myself, as you said, and the other one Ertan Sarıdoğan. And we will now move to Dr. Popov, but we have just quick two questions, and let's just give some answer about this one in this period. The first one, Elif Ganim Aygün, she is asking about does the patient feel pain during the procedure?
Excuse me, do you hear me?
Yes.
Okay. The patient doesn't feel any pain during the surgery. That's why we are using anesthesia, but it is not a general anesthesia. It is they are giving a small anesthetic drugs during this operation, and these drugs gives a sedative anesthesia. So the patient doesn't feel any pain during the surgery.
And the other one, Alperen Aksan, he is asking about considering that this procedure for uterine fibroids induces coagulative necrosis without tissue extraction. How can we accurately assess long-term oncology safety?
Yes, there are some publications about this issue. They performed before the procedure biopsy in the myoma, especially in Spain. There are 2 studies, and they didn't see any malignant cases at the end of the procedures. It is very safe. But if you think during your preoperative evaluation, the myoma is highly vascularized, highly continuous, very vascular system is very huge near the myoma, or the myoma is very big, or there is some differences in the myoma textures or ultrasonographic views, such as hypo and hyperechoic areas. In this case, if you have some suspicions about the uterine sarcoma, in these cases, you don't need to do such kind of procedure. But it is very safe procedures. Till now, I look at all of the literatures, but there is no leiomyosarcoma after these procedures. So it is very safe. As you see that also, the leiomyosarcoma incidence is less than 1%, less than 1%. So it is very safe procedure.
Just the last question. We will talk about this issue. A lot of questions now. I have 5 more questions in the panel. Vice versa, Dr. Kale, if the patient has already sarcoma in this procedure, we don't know sarcoma or not, Is there another side effect, another low prognosis, bad prognosis, something like that?
In the literature, there is no published study about this. So there is no, we cannot say that in the current literature that it can worsen the prognosis or not. We cannot say for now. But there is no literature. But if you really have high suspicions about the leiomyosarcoma, I advise you not to do this operation. But for now, there is no literature.
Okay, no data. Okay,
Yes.
now we will move on to Moscow, and Dr. Popov has send us the pre-recording his lecture, and he will be as a live at the panel after the lecture. Let's start with his lecture. Dr. Alexander Popov. The title will be Minimal Invasive Surgery for Adenomyomectomy.
Dear colleagues, dear friends, first of all, I would like to thank the organizing committee to invite me, being one of the part of your very interesting and a very important lectures. I tried to share our experience, how we can treat surgically adenomyosis. I don't have any kind of conflict of interest. You know well how we can treat adenomyosis. We can do surgery. Of course, we can do radical surgery, or to be more conservatively, you know about uterine arterioembolization. We can use ultrasound surgery or another kind of power surgery for adenomyoma. And of course, we use a lot hormonal therapy. We can use GnRH, Dynagest, intrauterus device, and some kind of new medications such as aromatase inhibitors, inhibitors of angiogenesis, or some kind of experimental options to treat adenomyosis. As about radical surgery, total gastrectomy, vaginal or laparoscopic or open, should recommend strongly, because if you perform subtotal gastrectomy, this patient will have some problem with the cervix, because the disease will be continuing, and this patient will back in your department to remove cervix after subtotal gastrectomy. That is why, again, a total laparoscopic gastrectomy can be method of choice, and you can find another phenotypes of endometriosis and treat at the same time. As for conservative surgery, you know, in case of cyst form of adenomyosis, cyst ablation by hysteroscopy or laparoscopy, it's a method of choice in case of infertility or symptomatic cyst type of adenomyosis. Sometimes we can offer the patient with adenomyosis and abnormal uterine bleeding to use endometrial ablation, but we should estimate the advantages and disadvantages of this procedure, because if the disease is progressive after endometrial ablation, this patient will have pain syndrome due to the proliferation of tissue, and cirrhosis could be involved in this pathologic process and could be the cause of pain. You know, a lot of kind of conservative surgical treatment of adenomyosis. This is an old technique which was prescribed in 2006 by Dr. Takeshi. You see two flaps of adenomyomectomy. You can do this procedure laparoscopically or during open surgery. But the reason is to open the uterus cavity and try to remove by palpation control all pathologic tissue, and cover this part of the uterus by two flaps technique. a new method of adenomyomectomy, which was prescribed 10 years ago by Dr. Asada from Japan again. He used 3 flaps of adenomyomectomy, and again on the palpable control. What is a very interesting thing that most of cases which were prescribed since 1990 were prescribed in Japan. I cannot explain this phenomenon. Maybe this Japanese researcher combined more and more patients with adenomyosis, and today they have one of the biggest number of these patients in Japan. But you can see that approximately 2,400 cases which been operated in since 1990, and the number of pregnancy was great, and especially number of live births in this patient. It is more than 85%, and only 6% of incidence of uterus rupture. I think it's very excellent, work, and this author demonstrated very good result after adenomyomectomy. Another Japanese doctor, Nishida, prescribed electrosurgical resection of adenomyosis lesion during laparoscopy or open procedure, and he offered a special high frequency loop to remove all pathologic tissue, and after that to cover this part of the uterus with 2 or 3 layers of sutures. And you can see that they had approximately 1,500 patients and 2 years of follow-up. And you can see that the number of recurrence is not so big, only 10%, and only 5 cases of uterus rupture during pregnancy. But if you check these research more correctly, you see that the number of patients with this type of adenomyosis was approximately 90%, and the patients was younger than 40 years old. I think it's a good model of patients who is younger than 40 and who has a cystic type of adenomyosis, because in this case you can remove all pathologic tissue, and these patients have very good ovarian reserve, and you can estimate the number of pregnancy very high. A friend of mine, Professor Ukliada from St. Petersburg, he offered another type of surgery. He used, you can see on this scheme, special flaps, and use into a rule hemming it to the bottom of the defect, and cover the second flap up to the previous, and blocking this dead space to prevent any kind of problem with the uterus. The result is great. Now Nikolai published this paper where he analyzed more than 200 cases of patients with adenomyosis, and you can see that the pregnancy rate was more than 40% in group of infertile patients, and they have 31% of birth, and only 3 cases of uterine rupture or some problem with the placenta. I think we can have this kind of treatment in your arsenal of surgical technique, how we can treat adenomyosis. In our department, we use the interesting technique of lumbar suture to unroll two flaps inside this part of uterus after removing of nodule of adenomyosis. And after that, we block that space to prevent hematoma. You can see this procedure during laparoscopy. We can use and recommend to use cold knife to prevent some electricity and destroy a lot of healthy tissue. But the problem is to recognize the measure between normal tissue and adenomyotic tissue. And of course, if you remove a big part of the myometrium, it's a problem to close this thing. And you can see how it's useful if we use lumbar suture. This is another case which demonstrate the possibility to block uterus artery before adenomyotic tissue removed. You can see good view and how we can block the uterine artery by clips. And after that, we start to remove these pathologic tissue. And during last 2 years, we use ICG, this solution insert inside the uterus cavity to detect this cavity, and we try to save uterus cavity because today the paradigm of adenomyosis treatment is to prevent open the cavity. If you remember old technique of Bayasada, he offered to open cavity as large as possible, insert the finger inside the cavity, and on the finger control to remove pathologic tissue. But you know that it's very dangerous for uterus cavity because we can stimulate adhesion inside, and we can treat adenomyosis with successful, but we can have a lot of adhesion after this surgery. That is why today we try to identify uterus cavity, and ICG is very, very useful for this moment. And after that, we try to remove pathologic tissue and use the lumbar suture again to cover this wound. And of course, we can perform this procedure laparotomy during laparotomy. And again, this is a scheme, and it's how we can treat this big size of adenomyosis. And again, we try to prevent to destroy the cavity because it's not so easy to treat after that adhesion inside the cavity. Of course, today robotic is a good tool to perform all procedures, and we have more than 1,500 cases of robotic procedure in gynecology disease. And this is example how we can treat adenomyosis during robotic procedure. We use normally monopolar scissor, bipolar forceps, and again try to identify the margin between pathologic tissue and normal tissue, and again try to save uterus cavity to prevent intrauterus adhesion. Normally, we don't have big bleeding, because you know that one of the characteristic of adenomyotic tissue is fibroids, and that is why we cannot estimate this bleeding so big. Again, you can see that we tried to identify the uterus cavity and tried to be close to, but not open, to prevent post-op adhesion inside the uterus cavity. This is a good example in case of focal adenomyosis. But unfortunately, in case of diffuse adenomyosis, this procedure is very, very difficult. And it's very difficult to identify where can we stop to remove the tissue, because it's really cytoreductive surgery, not radical surgery. And the end of the procedure, we start to to use suture. This is a monofilament suture, and again we use suture by Lambert to block dead space and prevent the hematoma and prevent some problem with the uterus scar. And the end of the procedure. Later, I will show you our result and how many patients were pregnant. And again, how we can prevent bleeding. We recommend to clamp the uterus artery, because in this case we can save more than 100 milliliter of blood. This is our experience during last 9 years. 100 patients were operated in our department. You can see the mean age of these patients, and approximately 50% from them were operated laparoscopically, 50% during open surgery, and only 4 cases were operated robotically. You can see the result, and we have only 2 cases of recurrence, one after laparotomic adenomyomectomy. This patient had 6 months GnRH treatment, but unfortunately 2 years later, during ultrasound examination, focal adenomyosis was identified, and she operated again by laparotomy, and now she is well, and she doesn't have recurrence. Second case was after robotic-assisted adenomyosis resection. She used Dianagest during 6 post-op months, and today focal adenomyosis was identified, and she continued to treat this disease by medication. She used Dianagest again with a very good result. We have 12 pregnancy among 28 infertile patients. 5 of them finished by labor, and 9 has a delivery, and 3 this patient had miscarriage in the early stage of pregnancy. You can see that 5 from 12 pregnancy were spontaneously, and 7 after IVF protocol. I agree with Dr. Asada. He published these very good conclusions that in case of big size of adenomyotic nodule or diffuse form, open surgery is preferable. Of course, we can change our strategy during procedure from laparoscopy to open, from robotic to open, but of course, we can estimate before surgery the advantages and disadvantages of our procedure. Not so many papers which confirmed the role of robotic-assisted surgery in case of adenomyosis. It's only one which was published in 2024. This author underlined that it's really more comfortable for a surgeon, and you can see very clear differentiation between two types of tissue, adenomyotic tissue and normal tissue, and you can see that the number of laparotomy after robotic assisted surgery is less if you compare with laparoscopic approach. Today we can say that we have three models of patient who is a candidate to treat adenomyosis surgically. First is a patient with symptoms such as dysmenorrhea or hypermenorrhea, which is resistant to medical approach. Or a second candidate is infertile and recurrent miscarriage patient, when we understand that this adenomyosis can be a cause of miscarriage. And the last group of patients who desire to preserve fertility or the uterus. And of course, in this case, we can offer a cytoreductive procedure to treat some symptoms and at the same time to save the uterus. And of course, in all these cases, we should estimate the benefits and risks of our surgery, because unfortunately, till now, we don't have the absolutely understanding surgical strategy. And again, this is a very good scheme by Dr. Asada, who is a candidate for adenomyomectomy. And he underlined that focal adenomyosis is the very good option for patients. It should be young patient, younger than 39 years old. And of course, a patient who has a good ovarian reserve. In this case, we can wait a good result after surgery. There are two things inside the box and outside the box. And at the end of my talk, I would like to focus into these things. First, inside the box, we now absolutely understand that we have low effectiveness of medication. And I said before that we don't have surgical standards how we can treat adenomyosis. And my opinion is we overestimate of surgical treatment result, and we estimate and overestimate, but patient too. And from time to time, we have to talk with the patient during long period to understand the advantages and disadvantages of this surgical procedure. What is it more important, that most of professional society doesn't support the surgery as a method of choice in adenomyosis treatment. But again, we absolutely understand this partial organ removal cannot treat the disease, because it's absolutely clear that it's disease inside or all of uterus. Of course, we can remove this part, but we cannot be sure that the tissue close to our removal tissue is absolutely well. And I know that all of us understand that adenomyosis is a system-based disease and requires system-based treatment. And maybe in the nearest future, we will have a big list of medication and could prescribe our patient personally based medication. At the conclusion, I would like to say that we have a good result of another kind of endometriosis surgery. We can do bowel resection, ureter reimplantation, but we don't have the same successful result in adenomyosis-associated conservative surgery as well. Although pregnancy rate after conservative surgery is high, the live birth rate is much lower in case of severe adenomyosis. If IVF or reduction surgery are not effective, surrogate mother is the only decision. The quality of embryo, unfortunately, in adenomyosis-associated infertility does not suffer. And maybe in the future, we will offer this patient uterus transplantation as one of the method of solution of this problem when the uterus is close to infertility. Thank you very much again, and I will be with you at the end of this session. Thank you very much.
Dr. Popov, you are here, right? Can you hear us?
Yes, I hear you.
Okay, you will be in here, right? We will.
Yes.
Okay,
Yeah.
please stay there. Thank you for the really good lecture that sent us for the presentation. And after the Gabby's presentation, we will discuss the questions at the panel, right?
Yeah, thank you very much. Thank you.
Okay,
I will
okay.
do. And again, thank you very much for your invitation. And nice to see you, but through the internet. But it's a big pleasure to see you and a friend of mine, Ahmed Kale. Good words.
Thank you. This is our pleasure because it's Christmas time and you just accepted, both of you, this presentation, this webinar. Thank you on behalf of the society. Gabby, you are ready?
Yes, I'm here. Engin, I'm so sorry I'm stuck in traffic, but I will do the presentation. Maybe if you can take a couple of questions from Professor Popov, I will arrive to my hotel room and I can be well set. I need 5 minutes, almost there. Otherwise, I can present from my cell phone.
Okay, sure. Okay, let's start. Dr. Popov.
Yeah.
One of questions, do you have any strategies or recommendations to prevent recurrence after adenomyoectomy? And the second one, is there a place for routine progesterone support in pregnancies following this kind of surgery?
It's a very good and important questions. And first, of course, we are thinking and rethinking about the strategy how we can prevent recurrence of adenomyosis. The rate of recurrence of diffuse form adenomyosis after cytoreductive surgery is unfortunately high. In my group, it's approximately 30%, but most of these patients doesn't have any kind of symptoms of recurrence adenomyosis. That is why we are only check this patient without any kind of treatment. But after surgery, we recommend strongly to stop menstrual function during minimum 6 months to have the time to recovery of the uterus, and we hope that this time is enough to have a good scar after our surgery and prevent some kind of obstetric complications. And a second one about progesterone support if this patient are pregnant. We use the normal typical kind of pregnancy recommendation with adenomyosis or without adenomyosis, and from time to time, we recommend progesterone support. It depends she has or not adenomyosis.
And another question from myself, do you have any interval between the surgery and the next pregnancy? How many months or year you want to save the patient to wait for the next pregnancy?
It's a very disputable question because some people concluded that it's enough 4 months, no more. But in my department, in my institute, we wait 6 months. It's the same time when we remove myoma. We checked the scar of the uterus, and we don't have any problems with the scar in my group in after myomectomy or after adenomyomectomy. It's unfortunately very small number of patients who has had delivery, vaginal delivery in group of adenomyomectomy. But I think if we find a good quality of uterus scar after adenomyomectomy, we can recommend to wait pregnant after 6 months.
Okay, in your practice. Another question, do you suggest any barrier gels to prevent the endometrial adhesion because you're open the cavity and to close the time? Do you use any barrier gels to prevent the intrauterine adhesion? I mean the Asherman syndrome, something like that.
Yeah, as I said before, today we change the philosophy of adenomyosis surgery because 5 years ago we used open technique to open uterus cavity as large as possible and remove the pathologic tissue under finger control and Asada technique example. But today we try to save the uterus cavity without any injury, any distortion, because you're absolutely right that when we treat adenomyosis with the open technique, the number of Asherman syndrome in this group is so high, and you know well how it's difficult to treat this symptom. You can treat adenomyosis with very successful result, but this patient can have very strong intrauterus adhesion, and you can stop your treatment, I mean hysteroscopy adhesiolysis, because the adhesion is repeat and repeat and repeat again. And that is why it's very important, if you open uterus cavity, to use gel inside the uterus. Normally, we use anti-adhesin. This is a South Korean anti-adhesin barium, and I think it's a good model to prevent intrauterus post-op adhesion.
Okay, thank you. We have a few more questions, but we will discuss after the Gabby presentation. Are you
Okay.
ready, Gabby?
Yes, I am ready.
Oh yeah, Gadi,
Okay,
hello, how are you?
we already introduced you, both of you, at the beginning of the presentation. Please,
I will
the
share my
title.
screen.
Okay, the title will be Dr. Ibn Mohammed from the USA about and the robotic myomectomy. As you know, he is very famous about the robotic surgery, especially for the endo and adeno. But this time he will speak about, I will listen to him as a first time in this subject, myomectomy. Please.
Very good. Thank you so much for having me. And sorry, it's crazy today with the traffic. So my disclosure, I'm a speaker for Intuitive Surgical. I'm gonna talk to you about like myomectomy. Myomectomy is a very, very surgically simple surgery, but strategically it's very complex to plan. And I believe with myomectomy, we have to have a good strategy because unlike other surgery for endometriosis, we're worried about the ureter, we're worried about the nerves, about other organs, the bowels. With myomectomy, the only thing you need to worry about the cavity of the uterus, but mainly the strategy on how you do the incisions,
how you do with minimally invasive surgery, how you set yourself for success are key. So I'll walk through some tips and tricks that I utilize in my myomectomy that will help me, and then I can talk to you about patient selections and operative to overcome operative mishaps. We know nowadays that the age of myomectomy is shifting. Before, the childbearing age was younger, and nowadays the age of childbearing is shifting to be later. Because of the recurrence of fibroids, and the recurrence fibroids depend on the number of fibroids, many times, if we remove more than 5 fibroids, the chances of recurrence at 5 years is around 85% versus 30% if we remove 1 fibroid. So considering that the age of childbearing is delayed and the recurrence of fibroid is very high, now we found that it's not uncommon for patients to do even multiple myomectomy before they have kids. And you can see here, many of our patients in between 35 and 45 end up having myomectomies. So the myomectomy, unfortunately, for the hysterectomy, we have most of the hysterectomy are done minimally invasive surgery. For the myomectomy, as you can see in the US, 30,000 myomectomy are done. Most of those are still done in laparotomy fashion. So there is a lot of room of improvement to shift the myomectomy to a minimally invasive myomectomy. And then a robotic surgery, considering that it will help the surgeons to suture and reconstruct the uterus more precisely and at ease, especially for posterior fibroids where we ergonomically face many challenges in laparoscopy. So the robotic will be an essential tool to shifting all those myomectomy from being laparotomy to minimally invasive surgery. So the most important thing is we all start, where do we start from myomectomy, and then where do we go? Because most of the time, many institutions have a limit of the number of fibroids if they need to do a myomectomy. For us, when we started simple, and then now we do 100% of our myomectomy, even for uteri as big as 5 kilograms in a minimally invasive fashion. So it's key to training not only on the techniques of myomectomy, but also on preoperative optimization of patients for myomectomy. Start with smaller number of fibroids, master the minimally invasive technique, and then track always your progress, your OR time, your estimated blood loss, how we can minimize this. And this way, we can build up the complexity through the years. So easy to master the technique, and set always yourself for success by optimizing the patient selection. As you can see here in our department, when we started, we used to do 70% of the myomectomy in minimally invasive surgery, and now almost 100%, 99.9% are done. And this is all the myomectomy that we see. We're not selecting myomectomy and checking the conversion rate. So most of the myomectomy rely on the capsule dissection, different techniques for capsule dissection, the myoma removal, how we can remove them, and the suturing for reconstruction of the uterus. The advantage of the robotic platform, it will help you to tailor for the patients the best route. For example, when we do multiple port, 4 arms for complex myomectomy with an assistant, we can do reduced port with an assistant, we can do reduced port with no assistant, and we can do single site. So depending on your experience, your expertise, the complexity of the case, you can tailor how much minimally invasive approach you want to do. So the assistant port, we have to think always when we have an assistant, especially in robotic surgery, what is the role of the assistant? In laparoscopy, your assistant helps you actively by doing the tenaculum, pulling, pushing, doing all these kind of things. In robotic, the assistant will become to just pass the suture and do some suction and minimal assistance. So this is the value of robotic surgery. It will enable you to be more autonomous in complex cases like myomectomy. The port placement in hysterectomy, we always, for all the hysterectomies, I place my camera in the umbilicus port because the target anatomy is usually in the pelvis, uterine artery, vaginal cuff, IP, they're all in the pelvis. So the umbilicus will provide me a visual access to my target anatomy. In myomectomy, you have to shift your ports higher depending on your target anatomy. And then we usually advise that there should be a distance of 8 to 10 centimeter from the proximal target anatomy from the optics that you do, and also around 8 centimeter from the ipsilateral target anatomy to your other robotic ports to enable full range of motion of your robotic ports with the wrist and to enable full functionality of all your ports during the surgery. I standardize my robotic instrument. What I use is a forced bipolar and monopolar scissors for enucleation, ligation of the uterine artery. I use a robotic tenaculum and a suture cut to enable me to enucleate the tenaculum and the suture cut to cut my suture myself autonomously and then to suture. Now, I know many of the surgeons utilize forces and different kind of vectors of pull in laparoscopy. In robotic, the 360-degree tenaculum will enable you to enucleate fibroids in a more, in a gentle way, minimizing the traction, the avulsion of the endometrial cavity, especially when you deal with type 3 type 3 fibroids or type 2-5 fibroids. So if we're going to simplify the procedure, it's about uterine incision, enucleate the fibroid, and then you do the myometrial closure. So it's a very technically simple stuff, yet strategically complex. For me, I utilize those tools always. I repeat the same tips for myomectomy. I always do transverse incision. In one exception, if we have a transmural fundal fibroid, that if we do a transverse incision, we might transect the fallopian tube muscular part. So we do an oblique incision that we can rotate, twist the manipulator to make it a transverse incision when we suture. Avoid small incisions. Small incision, you start digging yourself in a big tunnel where you can create a lot of dead space that will compromise the healing of the myometrium. At the same time, you end up having more incisions to correct, and that will take more time. So use incisions strategically to avoid what I call fibroid dystocia, when you start fighting to remove the fibroids from a smaller incision, and also to enucleate multiple fibroids from the same incision. Avoid at all cost the Swiss cheese uterus, the uterus that has multiple holes that will look like as a Swiss cheese block. So here you can see an example of a myomectomy. You can see we do a transverse incision. We cut all the way through the capsule. We grab with a single tooth tenaculum, and then we extend the incision to remove more fibroid from the same incision. And we utilize a very similar technique to what we used in open surgery when we cut around the fibers of the muscle of the uterus or connective tissue, getting the fibroid, and then we try to enucleate the fibroid mostly with traction and counter traction and minimal energy use to not to desiccate through the myometrium and compromise the vascularization, which will decrease the healing. This way, what we can do is we can try to minimize the energy used, and then at the same time promote better healing after reconstruction of the uterus. And then what we do is usually we remove, enucleate the fibroid, and see how the tenaculum is an active hand where it helps me rotate the fibroid, pull it down, pull it up, and then readjust the pull to minimize the the erroneous vector of pull, so this way your enucleation will be faster. I'll show you, we use a preloaded bag to keep the fibroids collected in a bag, and then we go after a transverse incision strategically to remove as many fibroids as we want from that same incision. This will keep the closure of the cavity very easy and very simple. You can see here, we can remove one fibroid, put it back, and then go back again to remove another fibroid and a third fibroid. This way we can get all the fibroids out, and at the same time we're enucleating those fibroids. Closure, one thing is the ease of closure and the precision in the reconstruction of the cavity. So you can see we use always barbed suture. Barbed suture is not because it's easier not to do knots. Barbed suture are engineered to maintain better perfusion in the tissue. And better perfusion means better healing, means less infection, and means less necrosis of tissue, and we don't constrict their blood loss. So barbed suture is not because of the ease of suturing and you don't make any knots, rather than it promotes better healing and better perfusion through those. So this way we can minimize theoretically the chance of rupture after a myomectomy, especially a complex myomectomy. So you can see we utilize these techniques, the suturing will become easy, and then at the end, the reconstruction of the fibroid, it will become very easy and controlled. And the most important thing for us when we do fibroid surgery is to oppose the edges to minimize the chance of adhesions, even though it's a minimally invasive surgery. But if you leave a raw surface of muscle, the chance of adhesion is theoretically increased. So we publish a lot of papers on tissue extraction and containment for myomectomy, but this is what we use currently. We found it the most efficient. We preload a bag, and then when we preload the bag, we'll deploy it inside the abdomen. I will put it on the ipsilateral side of my tenaculum. This way, it will enable me to place the fibroids inside the bag. Anytime I remove a fibroid, the nurses are keeping account of the fibroids inside the bag so we can count them. And in this way, my tenaculum does not cross on the contralateral side to place fibroid. It's on the same side of the tenaculum. Tissue extraction, it's published in the JMIC. It's a paper roll technique. We utilize it for fibroid. We place the Alexis retractor inside. We utilize a towel clamp with only a knife. We don't utilize any power morcellation. And then it's really easy and reproducible, this technique, to remove multiple fibroids. And I can tell you, you can remove far more quicker fibroid with this technique. They are contained, that minimizes the chances of spill of fibroid pieces inside the abdomen, and at the same time decreases the chances of leiomyomatosis after a myomectomy. The complex myomectomy is safe and feasible, and we publish more complex cases. Again, this is another paper in the JMIC talking about the complexity of myomectomy. I would suggest that after 4 hours of minimally invasive surgery, you lose most of the benefit of minimally invasive surgery. That's why efficiency and a good strategy and standardization of technique will minimize the chances of conversion to open surgery and will maintain the benefits of minimally invasive surgery. Patient selection is key because many times we see same number of fibroids, same placement of fibroid, but it translates to a completely different surgery. So that's why we order for all complex myomectomy and MRI. And on the MRI, we don't look only at the location and the number of fibroids. We look at the fibroid borders, we look at the fibroid consistency, we look at the thickness of overlying myometrium and the proximity to endometrium. And then this way, for example, here, we plan the placement. We have two fibroids. This is the uterine cavity, one posterior fibroids, one anterior fibroids. Where do I place my port if this is the umbilicus? I will place my port in this case in the umbilicus because this is where I will do my incision. This is only serosa. If I do my incision here, I will end up placing my port higher than the umbilicus. I will end up transecting a thicker portion of the myometrium that will make my enucleation more bloody and taking longer. Also, my posterior fibroid, I could potentially cut it from here, but I will transect the cavity in half if I have to make my incision posteriorly, and this is a challenging fibroid to extract because we're extracting it through the long axis. So a larger incision is advised. So see, with simple stuff, you can change the quality. Here, I'm going to show you multiple fibroids with the same size on the MRI that will translate different surgery. Like, look at this fibroids, 2-5, around 7 times 5. It's close to the endometrial cavity, but we look at the border of fibroids. These are smooth borders. The fibroid is homogeneous, is not degenerated. So this is the white pearly fibroid that will enucleate really easy. And this is a 15-minute, 20-minute case. Myomectomy, that will be very easy. Looking at the same fibroid, look at the borders. These are crenulated borders. This fibroid is degenerated. So crenulated borders make more connective tissue and more myometrial fibers in between the fibroids holding it. So the extraction needs to be more strenuous. You need to utilize more energy. There are lots of bump and it doesn't enucleate smoothly. Plus this fibroid is degenerated. So see a very different case with a similar size of fibroid surgically. The third one, same size of fibroid, 2-5 has been described. It's actually an adenomyoma with no valuable borders, and the 3 of them on ultrasound were the similar. So I would encourage the surgeons to get to know how to read their MRIs and plan the surgery based on the images rather than on the reports, because many times on the reports you cannot pre-plan your surgery. And this is another fibroids with the same size, but look at the thickness of the myometrium, overlying myometrium. This will make the enucleation more difficult, and then the reconstruction into multiple layers, and then this is a completely different surgery with a amyloid degeneration of a fibroid, which will be very soft. So these are different consistency and location and overlying thickness and borders of fibroids that translated into different surgery, even though these are single fibroids, similar size, but they're completely different surgeries. What we do for all myomectomies, we try to prevent the bleeding. The bleeding could be prevented by multiple ways. We use sometimes vasopressin, a diluted solution of vasopressin. We use 20 units in 200 cc's or 10%. We inject subserosally to make everything whiten, and then this way we can carry the procedure. We can use also a tourniquet. We use it sometimes for cases of adenomyosis and sometimes for cases of fibroids. You can place a tourniquet around the internal cervical os, around the uterine artery, that will decrease significantly the blood loss or the pulse pressure to the uterus, and you can perform the myomectomy after that. We prefer utilizing uterine artery ligation with bulldogs. So even with this example where we have a fibroids that is in the broad ligament, you can still, with the use of robotic surgery, dissect the uterine artery at its origin through a standardized way, either a lateral approach or a medial approach, and get to the uterine artery at its origin and place either Surgiclip or bulldog clamps. And you can see here we dissected the uterine artery, and then we place bulldog clamps on the uterine artery and on the uteroovarian to minimize the blood flow. And you can see the bulldogs, how we place them around the uteroovarian as well. These bulldogs, if you don't have them usually in the urology tray, if they do any kidney surgery, they can be available and then you insert them. And with the robotic surgery, it's easier to apply them as a surgeon rather than let the assistant apply them, especially in larger fibroid where the ergonomy of the assistant is not very easy. Surgery clip sometimes we utilize, where we can place the surgery clip around the uterine artery and the uterovarian if you don't have the bulldog, and that will decrease significantly the pulse pressure. If we're doing the fibroids for patients who do not desire pregnancy, but they desire to keep their uterus, I counsel the patients on leaving the uterine artery clamped because it decreases the chance of recurrence of fibroids. And this is the way you can remove it. You can slide it out. Avoid using hemolocks because hemolocks, you cannot slide it out. We know all our myomectomy are discharged, 90% are discharged the same day home as an outpatient, and the remainder is discharged the next day. So myomectomy could be done in an ambulatory centers. We know the importance of the predictors of overnight stay, and then either the late surgery time or the anemia. The anemia is extremely important to optimize and manage before a myomectomy. And you can see with robotic surgery, patients have more number of fibroids removed compared to laparoscopy and less blood loss and quicker OR time compared to laparoscopy. Nowadays, we map all those fibroids with augmented reality techniques, and we publish infertility, sterility, and in JMIG about those techniques, how you can color code the fibroids and how you can overlay the images of the fibroids during surgery to extract those fibroids and then minimize the chances of missing fibroids. Again, with augmented reality nowadays, we can understand the direction of the fibers of the myometrium, and then we can utilize incision that are optimal to go around the myometrial fibers to minimize the damage to the myometrial fibers, as you can see here. So the incision, if we make it around the fiber, we can minimize the damage and we can restore the integrity of the myometrium. So in conclusion, myomectomy is feasible with the robotic and minimally invasive surgery. It should be the optimal one. Optimizing patients by IV iron, decreasing their anemia, intraoperative efficiency will lead to successful minimally invasive surgery with least narcotic use during this procedure. Thank you very much.
Thank you, Gabby. Really fantastic. We have just 10 minutes. That's why we will be in a short time. One of the questions before that one, do you have any radiofrequency ablation, Dr. Popov, Dr. Mohammed, in your practice, radiofrequency ablation for the fibroids and the adenomyosis? Any experience?
In my practice, we don't have this experience, but I know that one clinic in Moscow, they prefer to use radioablation in case of adenomyosis, and they reported approximately 100 patients with symptomatic adenomyosis with a good result. But we don't have about the pregnancy rate and the obstetric complication, only how we can treat bleeding and pain.
Gabby?
We tried a couple of times radiofrequency ablation, especially Acessa in the US. For me, I think radiofrequency ablation might have a role for one thing. Patients who are contraindicated for longer surgery or more complex surgery might have a role as a procedure where you can, for sometimes you can incur more damage if you're gonna chase smaller fibroids closer to the cavity. But also when you become very efficient in myomectomy, you don't see it fit in your practice because we provide a complete removal of the fibroid. But for certain surgeons who do not have the skills of doing complex myomectomy, it's a powerful tool to offer their patients a minimally invasive approach.
Thank you. Dr. Kale, one question. You said the limit for the just 3 myoma. at the one time. What is the reason of this one? Can we do it the 4, 5, 6, something like that in the same time?
So this is a question that I ask for people who have a limit for fibroid. What if you have 3 myomas and a 4th and 5th myoma pedunculated? Would you stop the surgery? So, I believe there should be no limit. The limit only are not based on scientific evidence, it's based on surgeon skills.
The question about the radiofrequency ablation, not for the surgery.
If
Is
you
there
look, yes, if you look at the data about and literature, the limit approximately 7 centimeter or 8 centimeter, and not more than 3 myomas. That's why if you extend the myomas and 4 and 5 myomas, it means that the time is prolonged. Your procedure time is prolonged, and also you're attempting. If the myoma is very big, it is not so easy to target the myomas, because if you target the one side, the myomas, and the hyperechogenic rim is increasing, and afterwards you are withdrawing the needle and inserting the needle another side. So you are making lots of punctures at the same time. So it is increasing the operation time. And also if the myoma is very big, more than 7 or 8 centimeter, the coagulation necrosis efficiency is decreases. So the most efficient size is 7 or 8 centimeter, and not more than 3 or maximum 4 myomas, because your efficiency of the radiofrequency ablation is decreasing for in terms of menstrual bleeding, in terms of pain management. So this is an advisable size and advisable numbers of the myomas.
Another question. This patient has a diffuse adenomyosis around 8, 9 centimeter with the sonography, and she desires fertility, and she has the plan for IVF. And before the IVF, do you recommend radiofrequency ablation or the adenomyomectomy for this patient, Dr. Popov?
It's important question. I think we in my practice we discuss this question with reproductologists from my institute, and last 5 years we prefer to perform adenomyomectomy because the result is not so bad, and of course it depends of your experience. When we started to perform this procedure, the result was very poor, but today we should perform our surgery better and better, and the result is better and better. Because when we performed hormone therapy 10 years ago, we had the good pregnancy rate, but the delivery delivery was close to zero, because most of patients had the miscarriage in early stage of pregnancy. And of course, we should involve a patient to discuss this question, because solution from patient side is important, and she can accept any kind of treatment, and support your idea to use surgery or use radiofrequency ablation. But we should discuss advantages and disadvantages without any kind of tricks for patient. I think it's very important patient solution. But in my daily practice, in my department, surgery is the number one in this case.
Thank you. Gabby, for this case, what's your approach?
Well, the key for adenomyosis surgery, and let me pick a bone with my friend Dr. Popov. We published around 11 papers on adenomyosis in the last 2 years. None of them made it to your presentation. So I want to say that for adenomyosis surgery, the key is mainly the indication. The surgery, once you plan the surgery appropriately, the surgery will become a technique. The indication we don't want, because the goal of the surgery is not to eradicate adenomyosis. There's no cure for adenomyosis. You're decreasing the inflammatory burden that will affect the endometrial receptivity and increases the chances of pregnancy. So first, patient age plays an important role, as Dr. Popov mentioned, less than 39 years old. Second, we have to ensure that adenomyosis is the sole impact on her fertility. If she has deeply infiltrative endometriosis, I would remove the deeply infiltrative endometriosis without touching the adenomyosis and try IVF. But after multiple IVF failure, and we know the only reason for her infertility is adenomyosis, this is when you get the highest value of adenomyosis surgery, because we can still, there are a lot of protocols to decrease the inflammation by GnRH agonist or antagonist before IVF. So if these minimal medical or pharmaceutical intervention were not done prior, I don't think surgery should be the first line, even if adenomyosis is shown on an MRI. Because nowadays we see a lot of patients 25 years old on an MRI with adenomyosis. We're not going to do surgery on these patients. Probably she will get pregnant without any intervention. So for me, making sure that adenomyosis is the sole abnormal finding in the patients that's causing infertility is the indication for surgical resection of adenomyosis.
Maybe this is another question from Dr. Usta from you. Do you think that SP robot has a good place for fibroid surgery, especially for tissue removal?
You know, SP is a fantastic tool. You can work, but still we don't have the instruments that we utilize for a myomectomy. So for me, even if you have a two bipolar and or one progress with one scissors, we need a tenaculum for a myomectomy. And with an SP, you don't have a tenaculum. You can make a single simple fibroid. We did it as a myomectomy with the old SP port. It's feasible, but it's not reproducible. So you need the right tools to be able to do the more complex surgery. But I think from ergonomic standpoint, you can do all the surgery that you want in multiport, similarly to SP. SP is a very versatile tool. It mitigated all the challenges that we faced with any single port stuff, but still we're lacking the appropriate tool to make it, to push it for cases like complex myomectomy or myomectomies.
And you said, Dr. Popov, Dr. Gabi and Popov, for both of you, in your presentation, Gabi, you are not using the power modulator. Just you are using the Alexis for the removal of the tissue.
Right.
This is another important point. One of the questions from Dr. Dages, she's asking about the latest ESCO guidelines say in the back morcellation, even in that one, there is some spillage from outside of the back.
Okay, so let me break this main stuff. When we counsel patients for myomectomy, we are not discussing, we are not avoiding the sarcoma. If the patients accept to do a myomectomy, it's a completely different issue than the hysterectomy. That means she accepts that we're cutting through the fibroid. Many of us cut through the fibroid. So if this is a sarcoma, we already spilled the tumor by doing a myomectomy. So now the sarcoma spillage will not become an issue in myomectomy. What becomes an issue in most of myomectomy is the leiomyomatosis, because the sarcoma risk is 1 in 10,000. The leiomyomatosis, by leaving big fragments of fibroids to be grown on the omentum or on the pelvic organ, is the main issue. Containing is not 100% proof solution, but it will be even more it's a risk rewarding, because the risk of leiomyomatosis is very minimal. Containing tissue with a very, very small risk of spillage will be better than opening the patient just because there is a risk of spillage. So we're talking about two different things. In hysterectomy, sarcoma comes into play, because when you start cutting in the uterus, sarcoma prognosis is worsened. But in myomectomy, the minute the patient accepted to do myomectomy, she should accept the risk. And most of these procedures are not directed to uterine sparing option only. It's mostly directed to fertility enhancing surgery, reproductive surgery. So those patients, they are accepting the risk of leiomyosarcoma. They accept the risk of leiomyomatosis. Our job is to minimize those chances by containment. It's not we're spilling a tumorous ovarian cyst in a cyst. So that's why those do not matter a lot in this situation.
Just one comment, because the chance of the sarcoma is very rare, 1 in 1,000, 1 in 700, something like that. This is another discussable issue. We have no time. Maybe we can discuss this one for is it cost effective or not to use that one. Dr. Popov, what is your approach for this patient? Power morcellation or open one?
Till now we use power morcellation, but we have a very good back for this procedure with the 3 laps, and we use power morcellation from Bova, and I love this technique, and this back prevent any spillage of cells inside the abdominal cavity. But I totally agree with Gabi that the risk of sarcoma is very, very low. That is why we have to talk about spillage of any kind of cells inside and residual myomas after myomectomy. We will see about this complication. But of course, we can do open technique like showed us, but in my department we prefer to use power morcellation inside the bag.
Okay, thank you so much. We have more than 5 questions, but there is no time. We already limit our time. Thank you so much. I learned some of them from this webinar, from all of 3. And thank you for the comprehensive summary lectures, and you showed us what you did. It's very, very important for this kind of webinars. Maybe we will meet you again the next year, another topic, another webinar, if you accept. Thank you so much. Have a good night, both of you. Thank you.
Happy New Year's. Happy New Year's, because we are waiting the New Year's, and we need a peace. Okay.
Yes.
Gabi, can I ask you to send me your papers about adenomyosis, because I found only 2 and I include in my presentation.
He is so upset about this one.
There's 11.
He will send you.
Yeah,
He will send
thank
you.
you very much. Thank you.
Dr. Kale, thank you so much. Thank you so much.
Thank you very much.
my friends.
Dr. Gabi, thank you very much. Dr. Popov, thank you very much.
Thank you. See you.
Thank you.
Thank you, our friends.